Good afternoon. Uh, at the outset, let me thank the organizers of this meeting. And my task has been very much simplified, and many things have been said by Dr. Kunal Javeri. So I would be saving some time in that. Let me tell you that obesity is a chronic progressive disease which has been defined by WHO, and it needs treatment. It is a costly disease. It is associated with complications, and if you do not recognize obesity as a disease, then you will not be able to address the obesity and the problems related to obesity. Now, if you look at the uh, previous experiences, when we did not know anything about impotency, then quacks were doing the practice and they had a treatment. Same thing for fertility issues. IVF came and we knew that no, it is a medically manageable disease. And likewise, when we have now plethora of drugs which can really help you to reduce weight, then obesity has generated a lot of interest. And my job is to talk about the pharmacotherapy, oral pharmacotherapy of obesity. Now, as Kunal said, there are a lot of things associated with obesity. There are metabolic issues, there are cardiovascular issues, there are diabetes, infertility, there are mechanical issues. So we must remember that obesity is a problem. Now, how to define obesity is a difficult task, and in that sense, Dr. Urman said whether you will go for BMI or whether you will go for DEXA or bioimpedance or body composition. No, but nowadays we have Narvaria also will agree to that. We can define obesity in a better way with some of the anthropometric definitions plus the body mass composition, which can tell you that this patient is obese and needs treatment. You can still further define whether how much visceral obesity is contributing to the patient and how much is the non-visceral fat in this patient. Now, once we believe that obesity is a problem, then naturally you need to treat. And up till now, when we did not have the treatment which was effective, powerful, and long lasting, we did not do much. And the most important treatment for obesity is prevention. If you don't allow weight gain, then you will probably prevent the obesity. The long-term pharmacotherapy should be an integral part of the standard care of obesity, because most of the times what happens, ભાઈ અમે તો ફલાણા બેનનું ડાયટ લીધું 6 મહિના અને પછી વજન તો ઉતર્યું પણ પાછું એનું એ જ થઈને રહેવું. કારણ કે the management of obesity is long term. It is not for short courses where you have some reduction of weight and you stop doing these things and again you gain weight. So what is important? Why it is important? Because body does not allow you to reduce your weight. He thinks that your weight is fine. Whatever, once a receptor setting is done, then if you are 70, they will not allow you to reduce weight from 70. If you become 80, then they will not allow you to reduce from 80. Because when you have energy restricted dieting, it is characterized by decrease in compensatory mechanism which will try for energy conservation, and then you have decrease in leptins, satiety hormones, decrease in energy expenditure, and ultimately you gain weight. So weight regain is a very important problem in those who intend to lose weight. Again, we have seen the lifestyle changes at the most will be able to reduce the weight by 2.6, but now with the advancement in newer anti-obesity therapy, we can reduce to the tune of 20-25% of the weight reduction with the medical therapy. And that probably should worry a little bit to Dr. Narvaria that we have a powerful drug like tirzepatide and then rituximab and even the oral orforglipron. All those drugs would be useful. And newer obesity medications can maximize the magnitude of weight loss and help to overcome the compensatory mechanism that induce weight regain, promoting sustained weight loss. Now, the benefits, when you lose waist circumference, you decrease your blood pressure, you decrease your A1C, you decrease your C-reactive protein and inflammation, you decrease your triglyceride, and you have even diabetes remission. If you reduce more than 15% to 20% of the weight, then your diabetes also can become less than HbA1c 5.7. So that is a very important thing. But as it happens in all sciences, the initial part of the medicine was a difficult thing, and that's why we have drugs which came and then we had to take off those drugs from the market because of the side effects. This is one important slide which I would like you to say that if you are overweight by 5%, the lifestyle will be able to help you. If you are overweight by 5 to 10% or BMI is above 30 or something, then only lifestyle will not help you to reduce weight. And if your BMI is more than 30 or 35 and you have some comorbidities associated with that, then you need to have a powerful drugs. And if your BMI is more than 40 and if you are super obese, then the only thing which would really help you would be a bariatric surgery. So you must remember, a patient who comes with BMI of 40 and you tell him that no, do lifestyle changes and get your weight reduced, that doesn't happen. So we must know the magnitude of obesity and in which kind of patients what would be the right treatment, that should always be told to the patient. So the pharmacotherapy decision, as I mentioned earlier, it depends upon not only the BMI, it depends upon the lifestyle, it depends upon the comorbidities, and it depends upon the goals of the treatment. So all these things are very important. So like patient who is 35-year-old female and wants fertility, then you need to be very aggressive in that patient and do the weight reduction at the earliest. What happened actually that obesity medications before 2012 were available. There are some medicines like pentoramine, diethylpropion, and benzaphentamine and all those, they were cleared for short-term use. Nowadays they are not used. The first long-term medicine which came in the management of obesity was orlistat, and that was approved in 1997. After that, we had a lot of drugs like fenfluramine, dexfenfluramine, sibutramine, rimonabant. Because of the complex interplay in the brain receptors and the neurotransmitters, these drugs were somehow taken off. And then there are drugs which are still available now. Phentermine, which is central noradrenergic, schedule 2 to 4, approved in 59. Then orlistat. I would mention couple of slides for orlistat, which will be very important to know. Thereafter, as Dr. Javeri mentioned, that there are different drugs working at different receptor level, like pentoramine, topiramate, and they would work on GABA receptors. Then liraglutide and semaglutide would work on GLP-1 receptors, and naltrexone and bupropion will work on dopamine, norepinephrine reuptake, and MOPR, that is also mu dopamine receptor uptake. So there are different drugs, and the orlistat would work on pancreatic lipase and will inhibit the action of pancreatic lipase. By that, it reduces the fat digestion and the undigested fat is excreted in the stool. So, lipase enzyme inhibition that covalently binds the serine residue of the active site of gastric and pancreatic lipase and irreversibly inactivating these enzymes, partially inhibits hydrolysis of triglyceride, reducing subsequently absorption of the free fatty acids and monoglycerides, and helps in reduction of the weight. Now, if you look at the studies, various studies have definitely shown the results better than the placebo. One study showed short study for 12 months, placebo was 6.6 and 9.7. The other study is little longer, and ultimately early state was proved to be better than the placebo, and it was better than the lifestyle changes for weight reduction. Safety, there were some issues with the increased liver enzymes, and that we must keep it in mind when we talk about early state. But nowadays early state is not available or not used to the extent which we used to use before the newer drugs which are available. Early state is very important point is that it works on the fat. So if you are not taking high fat diet, you are not going to be benefited by that. And the other important thing, when you take early state, you will have probably steatorrhea and sometimes the fecal incontinence and passing of stool without knowledge, and that is a very embarrassing and cumbersome side effect. So that is why we used to tell the patient that when you go out or you go to the party, please don't take early state, otherwise you will have a problem. So there are issues with early state. Then you can see from the mechanism of action indication, the BMI more than 30 and the side effects which I have already mentioned. And early state is a lipase inhibitor that produces a mean reduction of total body weight over 6 kg over 4 years time. One of the earliest marked anti-obesity treatment. Then came pentoramine and topiramate, and here the mechanism is it activates the sympathetic nervous system, decreases the feeling of hunger, and that is why it acts. After 1 year of the treatment of highest dose, the combination therapy decreased the body weight by 10.9% in people with obesity, placing phentermine topiramate as the top of obesity medicine. And then came, however, these combinations were still not available freely in our country. Then came the naltrexone bupropion, and that is also a drug. The mechanism is not exactly known, and the side effects of this combination was nausea, constipation, headache, vomiting, dizziness, and people failed to tolerate it well. And the combination therapy with a beneficial safety profile and demonstrated the efficacy to the tune of 5.4%. And last was the addition of lorcaserin, and then it came in the market. It was thought to be a very good drug, but lorcaserin was also associated with the valvular problem, and in Bloom study lorcaserin showed that it is not a safe drug, and that is why it was withdrawn from the market, and which had a very huge noise, but lorcaserin is not available. Then the last thing, the group of the medicines which now we have is as mentioned by Kunal, the liraglutide, which is 3 milligram for obesity dose. It is not the 1.8 or 1.2. So remember 3 milligram, which is not available in our country. Orlistat and naltrexone and pentoramine topiramate, I have already told you. But the other oral drug, which is semaglutide. Now semaglutide is cleared as an anti-obesity medicine by 50 milligram. It is not the 3, 7 or 14 milligram, the Rybelsus, but it is the 50 milligram which has been designated for weight loss. And then there is a tirzepatide, which is also very promising injectable once a week drug, which will help us in the management of this obesity. As it is a first oral GLP-1 semaglutide, novel tablet developed for obesity management, the first one, and it delivers new possibility of obesity management with significant improvement to weight reduction with an established safety profile. It is a snack, there is a absorption enhancer plus the spacer, and this drug, although it is a peptide, can be absorbed through a gut and can have a beneficial effects. So I think the OASIS trial, which showed that statistically significant and superior body weight reductions compared to that of placebo with oral sema 50 once a day, which was comparable with the injectable Wegovy 2.4 milligram once a week with the weight loss of 15%. So 15% weight loss is between the previous oral pharmacotherapy and the surgical management. So, couple of slides. There are other drugs which are on the pipeline. I would mention Cagrisima, which is a very hot topic, but orforglipron is a very important drug which has finished phase 3 trial, small molecule, and the beauty of this drug is that it can be taken at any time of the day, without food, with food, after food, before food, and it has shown the beneficial effects more than semaglutide in the obesity management. So the future is, there are so many drugs in the pipeline, and obesity is considered to be a very important non-communicable health hazard which takes away lot of our means and our money in the management and for social also issues. So it has to be remembered that obesity is a disease and needs treatment. How you define obesity is different, but you have to define obesity. So there are, I think I would end here and I would hand over the mic to the organizers. Thank you.